All right. Well, good afternoon, everyone. My name is Casey. I work for the EMS for Children Innovation and Improvement Center. We would like to welcome you to today's Pediatric Readiness Quality Improvement Collaborative session. This is our 11th collaborative session, and this month marks the 1 year since the start of the collaborative. So we would like to extend a heartfelt appreciation to each ED site and their team for their dedication and perseverance over the last 12 months. We are encouraged by the great work accomplished and by each and every one of you and your efforts to improve pediatric emergency care. And we look forward to the next 6 months and what we can still accomplish together. So big round of applause to you all. Thank you for being here. Before we get started with today's session, we would like to acknowledge that the EMS for Children Innovation Improvement Center is supported by the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. A couple reminders. Portions of today's session are being recorded and will be posted on the EIC's website along with today's presentation. For nurses seeking continuing education credit, please add your first and last name into the chat, and we will share the evaluation link with you at the end of today's session. And we have a couple of the formal objectives for today's session. All right, so we will begin today's session by hearing from members of the NPRQI team. We'll be hearing from a couple of sites who will be sharing an update on their QI work, followed by an opportunity for all sites to take part in a discussion on SMART aims. We'll wrap up and share the session evaluation link for those nurses seeking continuing education credit. And as a reminder, there are 25 points of MOC Part 4 credit available. You can view the requirements for this under the participant details on the EIC's website. So please feel free to use the chat function and come off mute throughout the meeting for any comments or questions. With that, I'm going to go ahead and hand it over to our team from NPRQI. Joining us today is Dr. Sanya Desai and Liza.
Hi, everyone.
Okay. Should I go ahead, Liza?
Yeah, go ahead, Sanya.
Okay. Next slide, please. So we just wanted to take some time this morning or this afternoon to review with you some output from the data that has been entered into the NPRQI portal within the first year of beginning this collaborative. We pulled this data on June the 10th, so it's a little bit not quite up to date, but quite current. So this graph here is intended to depict how many charts have been entered by hospitals in the collaborative. So of the total collaborative, we still have about 20 sites that have not entered data, but we have 77 sites pictured on this graph that are entering data. Each site is represented by a number across the bottom axis, so the horizontal axis. So each bar represents an individual site. And then on the vertical axis is the number of charts entered. So you can see, we have somewhere between 4 and 6 to all the way up to 450 charts entered by individual sites. The orange line is the represents 30 charts, which is what we consider our baseline data. And so of our 77 sites, 63 have entered at least 30 charts, and the median number of charts entered was 80 in that first year. Next slide, please. We also wanted to highlight participation across states. We have about 27 states who are entering data into our NPRQI portal as part of PRQC. And of those, the darker the color, the more charts you have. Next slide. We also wanted to take some time to describe the cohort of patients that have been captured in our data portal for the first year of the NPRQI data set. So again, this is not completely updated, but any patient whose date of visit was between January 1st, 2023 and April 15, 2024 would be in this portal, in this cohort that I'm describing. Next slide. If you look down at age and gender, we had about 6,700 charts within that time period. The age distribution looks fairly even across age categories, so about 20% in the 0 to 2, and then 2 to 6, 6 to 12, and older than 12. There's also a relatively even breakdown in gender. Next slide. We also looked at the patient's insurance characteristics, and nearly 60% of these patients were publicly insured. Slide. We also wanted to describe a little bit about the clinical characteristics of our patient cohort that we saw in the first year. So of the patients entered into NPRQI, about 67%, as you can see on the left-hand side, the chief complaint type, 67% were medical chief complaints, another 25% were injuries, and then 7% were behavioral. On the right side, as for those of you that enter data, you know, we ask, as you're entering data, if your patient meets any of these bundles that are part of the NPRQI platform. The most commonly selected bundles were respiratory symptoms and vomiting. Most patients, however, did not meet a specific bundle. Next page. Perfect. We also wanted to describe the distribution of ESI triage levels. So we see that the most common ESI triage levels are levels 3 and 4, which represents the general PD population. And then on the right-hand side, we also wanted to describe the patient's dispositions, what happened to these patients at the end of the ED encounter. And we see here that about 74% were discharged home, roughly 12% were either admitted, and a similar number were transferred to another facility. We also wanted to take a minute to talk about a couple of data entry issues and patterns that we've noticed, and we wanted to share some tips on how to address them and also elicit some feedback from you all. So one of the things we have noticed is, as we would expect with manual data entry, one of the areas in the chart entry that is probably the most prone to human error is entering the dates and times. And so when we looked at some of our time metrics on the dashboard, so specifically the length of stay measure or time to first intervention, we've noted that about 3 to 7% of patients have a negative value for the time metric. We most often see this for patients who have an ED visit that starts in the later hours of the day. So for example, a child who comes in at say 10 p.m. and their triage time is, June 18th at 10 p.m. and their discharge time is June 19th at 2 a.m. Well, sometimes that discharge time might accidentally be entered as June 18th, and so you end up with a negative length of stay. And so those are some common errors that we have noticed. And similarly, we've also noticed a much smaller number, but just really abnormally large time intervals. So 3 months for a time to first intervention wouldn't make sense, or maybe a year for a length of stay hopefully isn't real. And so we did take a couple of corrective measures, and some of you may have heard from us as we were doing this. We did modify our dashboard such that any time value that's included on the dashboard would not fall in one of these categories. So if that number came up as negative, we would just exclude that chart from your site's dashboard calculation so that your numbers are not messed up. And then similarly, if you had a lot of abnormally large time intervals, we would also get rid of those. We also wanted to share with you that there is a mechanism within Clario to check your own date and time entries. And I will go ahead and show you that. So this is a screenshot of the data entry portal. So not the visualization dashboard, but this is where you enter data in Clario. On your project work list on the left-hand side, you should see a bar that includes reports. And so if you click on that, you should get a list of reports. And this is my view, so some of these would not be available to you. But the one that I have highlighted, the date and time check report, is one that is available to all level 2 or level 3 users across sites. And so through Clario, you can click on this data and type, click on the run button to run the report. And then this is what it looks like. I've changed the numbers, so none of those are real. But here is an example of what that report would look like. And what it does is it pulls out each date and time value that you have entered in FAAP and puts it in a spreadsheet for you to review. And so what we would recommend is perhaps once every quarter or once every 6 months within your capability to have a user at your site download this report and glance at the dates and times to make sure that these are, there are not egregious errors in there. For example, making sure that the date of disposition isn't before the date of treatment and the time of disposition makes sense. Slide. Another data entry issue that we noticed as we were running our patient profiles is the distribution of answers for our race and ethnicity questions. So as you'll see, for race and ethnicity, we found that about 25% of patients for race had a response of unable to obtain, and a similarly high response rate for ethnicity, a little bit lower, 15%. We dug a little bit into this further within our admin team here at UT, and we found that there were a few sites that were entering unable to obtain pretty uniformly for most of their patients. And when you look at the 15 sites that had a greater than 40% of patients that were entered as unable to obtain, that accounted for nearly 75% of the patients in the whole cohort that were unable to obtain. Similarly, we noticed that there were a few sites that often entered unable to obtain for about 90% of the patients for this. And so wanted to take a minute and check in with you all about data entry issues that I brought up, and then specifically the race and ethnicity issue. If sites would be willing to share, are there challenges in finding this information? What could we do to help you guys streamline some of this? We'd love to hear your.
So Sanya, there was a question in the chat that says, are children under 1 month excluded? We know that they're not excluded, but the way that we have our age categories listed in the data portal, they would, if it's a child that's maybe 2, 3 weeks old, they would just select 1 month, correct?
Yes, so you would select 1 month if it's a patient whose age is between 0 and 30 days, but we are not excluding anybody based on their age. We see here that one of we have a site that mentions that their patient access team is working on capturing these variables. Thank you for sharing that.
Sanya, I was going to say, when you were talking earlier about the date and time check report, I do know that sites are looking at that. We have had a couple of sites actually reach out because they're looking at their dashboard and they're going, wait a minute, this measure looks really, really off. How do I get more information about that? So we have provided some technical assistance to some sites and have directed them specifically to this report and where they can find that specific information on the performance measures related to time. And we do have some how-to procedures for sites that need to make any corrections to the data. We can send those to you as well.
Yeah, and then just to clarify, since we had a lot of questions about incorrect values showing up on the dashboard, we've now modified the dashboard to exclude those big negative values. So if you had it, for example, if your site entered a lot of incorrect time values, what you might notice is, say you entered 80 charts and for your weight measure and your pain measure, you have 80 patients included in the calculation. And then suddenly you notice for a length of stay, you only have 50 patients included. Well, the reason for that happening was likely that there were 30 patients for whom the time value was considered an outlier. And so it was excluded. So that's going to be the way you notice if your site is having a lot of missing charts for incorrect times. But hopefully with our errors, you're not going to see crazy high numbers anymore, crazy low numbers. See some questions. Let me look at the comments here. And then there's comments about there are hospitals where these are maybe not collected uniformly and you're working on collecting them. There's comments about being able to find them. And yes, I think that can be a challenge because often they're just on the insurance face sheet. I see Cassandra here mentioned that, oh gosh, that's rough. So having to actually print a face or to hit print for a face sheet to find the data, that makes it really hard to find. So thank you for sharing that. And then there was a question here about Hispanic or Latino in the race section. So we follow the CDC's and the CDC's rules about reporting race and ethnicity. So these are kind of nationally described categories. And so Hispanic or Latino is specifically included in the ethnicity variable and not in race. So when you're collecting data following the CDC rules, it should be, there should be a race category and an ethnicity category. And I'm happy to put a link to that in the chat. I can find. Thank you guys for sharing your thoughts. Any other comments from the NPRQI team?
No.
I think that's all I have on my end. Oh, there's a couple of sheets. What do you tend to do when, oh, these are sites are asking questions to each other. What do you tend to do when initial vitals does not have a vital, but it is recorded later? Michael, do you want to ask, do you want to clarify that question? Is that for the NPRQI team?
Yeah, like essentially it might not be captured in triage, but it might be captured as a reassessment. They'll do a full set of vital signs. But if you don't put it on the triage initial, then you can't mark it as a reassessment later. So sometimes you might have it where it's reassessed, it's assessed once, but not at triage, but maybe there'll be a blood pressure later, but wasn't one at triage. So it's like it was never reassessed, but it was assessed.
Oh, I can speak to that. Thank you. That's a great question. So my understanding is that it's not necessary that the entire set of vital signs has to be done in triage, just that it was done. So the first, there's a set of questions that asked, was this vital sign assessed? So for example, if blood pressure was assessed once, then, and it wasn't at triage, the first time that blood pressure was assessed counts as your initial measure. So if they were triaged and they didn't check blood pressure, but 30 minutes later or an hour later they did, then that goes in as your initial blood pressure. If they did a heart rate at triage and then 2 hours later did a second heart rate, then you have an assessment and a reassessment. So we're not married to kind of whether it was done at triage, just whether it was done at all. So if it was done once, it's an assessment. If it was done again, then it's a reassessment. Hope that answers the question. Okay, jump in if I didn't convey that right.
No, I think that answered it. Just to add to it though, is in the NPRQI measures related to vital sign reassessment, that variable only depends on a denominator of patients who had an ESI triage category of 1, 2, or 3. So the national steering committee that helped define these measures did not feel that vital sign reassessment was a critical element for pediatric patients who triage in categories 4 and 5. And so I also just want to clarify that yes, it's vital signs at any point in time, but for the purposes of reassessment, the denominator is ESI triage 1, 2, or 3. So the most critical patients who we recognize the importance of reassessment on because they're at higher risk for deterioration. I'm not sure if that answered the question too. I'm not sure if you were asking about the reassessment specifically for abnormal vital signs.
No, not specifically for abnormal, just for patients where there will be a reassessment later that captures it, but it's not captured initially. Because the question kind of phrases it as, you know, was there an initial vital sign other than kilograms obtained, which kind of then triggers the thought of triage vital sign rather than like, was it ever obtained?
Yeah, it is a challenge because, you know, obviously if it's an hour into the evaluation, then it's unlikely that it prompted decision-making related to ESI triage category and the like. So that's probably one where, you know, from the perspective of quality improvement, you might document that it wasn't obtained initially, but only later because you're trying to advocate for early vital sign assessment.
See a comment from Hazel. Very much agree with you. Challenging to collect base data. And ideally, yes, it should be self-reported, and it can be a difficult question for a registrar or triage nurse to ask. But you know, as we mentioned before, it should be something that is asked and answered, not assumed at any point. And so certainly we should be better at collecting basic and ethnicity accurately. I will say that perhaps one issue with our data entry portal is we don't have that other category that Hazel brought up. So any individual who's biracial or multiracial would fall into that. Thank you for sharing.
Thank you so much for sharing those updates. Liza, were there any other NPRQI updates to share today?
Yes, so if there are any folks on the call that have not yet started data entry, you would have received an invite for Wednesday, the 19th at 10 o'clock a.m. Central Time. We're going to host a PRQC NPRQI office hours specifically for sites that have not yet started entering data.
Thank you. Yes. We look forward to seeing some of you then. Right. And then more information to come for next month's NPRQI office hours as well in our monthly recap email. So be watching for that. So again, if you're unsure when your site will be providing an update, you can check the PRQC website under the general resources page or email us at collaboratives@emscimprovement.center and we can help you look at that calendar and make sure that that date works for you. But we would like to spend the remainder of our time reviewing SMART aims, as these are the roadmaps for our quality improvement work. They help us to specify exactly what needs to be accomplished, how success will be evaluated, and by when. Because without that framework, you run the risk of your quality improvement work becoming unfocused and impossible to measure your effectiveness. And joining us today, we have a couple members of our PRQC team to help guide us in this work. So we're excited to have them with us today. So as a refresher, we have our aim statement as a clear, explicit summary of what our team hopes to achieve over a specific amount of time, including the magnitude of change you will achieve. You might remember that SMART being specific, measurable, actionable, relevant, and time-bound. Saw a lot of sites using this formula today. By doing an intervention on the system, we will change some part or all of the system, which will the outcomes you choose by a specific amount of time. So wanted to share with you 2 examples of SMART aims here and get your feedback of which might be the stronger SMART aim. We can start there. We have option called the first one, 1 and 2. You can read through them, but the first one is by implementing online training modules on the importance of pain reassessment, we will increase the number of pediatric patients being reassessed, which will result in pain reassessment volumes increasing from 75% to 100% by December 30th of 2024. So that's SMART aim 1, and then SMART aim 2. We will lock our scales and weigh all children in kilograms by January 2025. So feel free to come off mute and offer some feedback on these SMART aims and what might be key takeaways by just reading them here. Which one might be the stronger example of a SMART aim? You can put the numbers in the chat too, whether SMART aim 1 or 2 might be the stronger of the SMART aims we have here. SMART aim number 2, though we'll lock our scales and weigh all children in kilograms by January 2025. That's our stronger example of being smart. Okay, what are some other thoughts on that? Maybe some votes for 1. And thank you everybody for adding your thoughts in the chat.
Number 1 is more of a process rather than a goal oriented, it kind of looks like, because it's more like, increasing a number, but it doesn't really say. It's more of like how you're going to do something and what your end result is, kind of that, but it's not really it's kind of a multifaceted rather than a singular idea.
Okay. Thank you. We comment about the second one, which is we'll lock our scales and weigh all children, needing more specificity. 1 might be more comprehensive and includes the process, helps provide that roadmap. If we were to edit one of these, if we might look at number 2, for example, what might be a way to make some edits to it to better provide guidance on how your team will accomplish a goal, which might be what's missing in the second one. Two has no goal. Yeah.
I think the goal is 100%. It's just not, it's not numeric. It says all children. So there is a measurable outcome, but it may not be achievable. Just to call out the A in SMART.
So what might be some edits we could make to that? And again, feel free to put it in the chat or come off mute. How might we rephrase that?
Casey, I'm happy to chime in.
Yeah, go right ahead.
I think these are just to wax and wane on these aims. I think one of the challenges is that the intervention is included within it, and that's not always kind of how SMART aims are written. It's fine if you know that this is the only thing that you can do and that's going to be your approach, but typically within our QI projects, we're really trying to take a multifaceted approach, looking at all the drivers, because simply locking the scales if someone, comes and unlocks them or takes a parent's estimate, or simply training on modules about the importance, neither of those may be sufficient to really achieve the results that you want. So I do think that both of these are specific about where they're trying to get. And I do think they're both potentially measurable. You can measure reassessment, you can measure the number of children that are weighed in kilos or the percent of children who are weighed in kilos. But whether or not they're achievable, particularly the second one, is a challenge. They're both time bound. They have a specific date by January 2025 or by December 30th, 2024. And I would say that they're both probably relevant. And if you're asking a specific question of, if I were going to rewrite AIM 2, which I think is what the question was, I might say by January 1st, 2025, so that it's clear that I mean by the end of, by January, what date we will ensure a 10% increase in the percent of children who are weighed in kilograms only. And I would probably specify only if that's really what we're trying to achieve. But that does require a baseline, and without that baseline, it's hard to know if it's achievable.
I think Hazel sort of got to that in her example in the chat. By December 2025, the percentage of pediatric patients weighed in kilograms will increase from a baseline of X to 100% by locking scales in kilograms. And our other comments here would just be 95% of children will be weighed in kilograms by January 2025.
I love what Brandon wrote too about formulating a measurable outcome, because if you bypass, then it may not really be relevant. So if the process in the ED is to constantly bypass scales, that may not be really what you're looking at is the scale, but rather what you should be looking at is how children are weighed.
All right. And then would there be any edits you would want to make to the first example? Right, hearing none. We did want to just refresh a little bit about SMART aims today and propose opportunities to connect with the PRQC team. If your site is looking for some advice or guidance regarding your SMART aim, feel free to reach out and we would be happy to set up a time with you. I also see chat or a comment just came in, Cassandra. 100% doesn't seem achievable, maybe a more realistic goal. That is a great point to make. Thank you for that. But so as you're moving through your QI project and you're looking to maybe reevaluate your SMART aim and need some guidance, please feel free to reach out and we can set up a time to discuss that with you. And we would look forward to that. Are there any questions or any other items you'd like to bring forward to the group today? We have a couple minutes for a bit of a Q&A if anyone has any questions. Great example of a SMART aim in the chat, Hazel. If there are any questions, feel free to raise your hand or just come off mute. Be about your specific SMART aim, anything going on at your site. We would love to hear from you.
I'd love to just add one more comment about SMART aims, which is that once you achieve them, doesn't mean that you stop there. And it's very reasonable that if you set your aim low initially, that you continue to revise it and, you know, continue to kind of grow your processes and or your performance over time.
Casey, I was going to say something similar to that of I have always found that when I've put together a SMART aim, I try to keep it super simple. So it's like we're focused in on one piece of it, even though it will implement or it will affect other things. I try to keep it super simple, and then in something, say for example, if you're at 75%, like this SMART aim here, pushing it to 85% for the first roundabout on this, so you start making progress towards the goal, so that it's not going from 75 to 100 is a big jump, but ultimately you want to get to maybe to that 100%. But if you're not getting there and it takes you 8 months to get there, a year to get there, you're going to feel discouraged when month after month after month after month you're not hitting that mark. So if you can make it a little bit more attainable, and again, keep it measurable, keep it simple, and then move forward. Once you hit that goal, now switch it over to, okay, now we want to, this was the pain reassessment, maybe it's basic reassessment on the patient, you know, like that if they're giving a medication, they're doing, was there any results from not necessarily just pain medications. So you can expand on it, especially as you're looking at those charts all the time now. Kind of like what Kate was saying, of where you do it sequentially, and then also you can expand it to other things as you go, but keeping each one of them pretty simple. I find that is very motivating for my staff to see this goal that we're achieving, and then now we're pushing it a little further, and now we're pushing it a little further. Just my thoughts.
Thank you so much. All right. Well, if there are any other questions, feel free to put them in the chat or raise your hand. But we did want to share with you a couple upcoming opportunities. There will be a fireside chat next Tuesday. It'll be a closer look at assessment. It's going to be a great opportunity. We'll be addressing ESI triage levels and hearing from some great speakers. So that information is on the PRQC website. The registration link was just put in the chat. So if you're able to join us, we hope to see you then. The recording will be posted on the EIC website for those who are unable to attend. And then we will see you back here next month on the 16th. And we look forward to hearing from additional sites and their updates. If you're not sure when you might be sharing your update, please reach out, or you can find the calendar on the general resources page. So we do thank you all for joining today's session. And as a reminder, if you're looking to obtain nursing CE, make sure that your first and last name is in the chat. And then you can scan the QR code, or the link will be in the chat for you to complete your session evaluation.
Casey?
Yes.
Stephen, I have one question. You're going to record the fireside chats, right?
Yes.
Okay, good. Because, yeah, I have a conflict that day.
Yes, the recordings will be made available after the session.
All right.
We will not be offering continuing education for viewing the recording. No, that's also a question I received recently.
Okay, noted.
Thank you. All right, well, thank you all for joining, and we hope to see you next week, and then we'll see you again next month.